Thank you for joining us on Salt and Pepper Unleashed. This ain't your grandma's nursing home. Today's episode is an important one that touches most families at some point, yet is often misunderstood, feared, or even avoided altogether. We're talking about hospice, but not hospice as many people think of it, hospice as it truly is. Our guest today is Dee Harding, COO and Administrator of Elevate Hospice, who is transforming the way people view hospice care, shifting the conversation from fear to compassion, from misconception to clarity, and from the end to a deeply supportive chapter focused on comfort, dignity, and quality of life. Dee is dedicated to helping individuals and families experience hospice not as a last resort, but as a powerful resource that brings peace, guidance, and meaningful support during some of life's most tender moments. In this conversation, we'll unpack the myths, explore the truths, and hear inspiring stories that illuminate how hospice can be a gift, helping people live fully, even in the final stages of life. So, settle in, take a breath, and join us as we reframe what hospice really means and why it isn't a word we need to fear. Dee, thank you for being with us today.
Thank you for having me.
All right, that's quite an introduction. This has got to be a good episode here. It's gonna be.
I think it's gonna be great. Yeah.
So, I just have to start off by letting you know a personal story that ties in just perfectly to kind of this introduction here. So, my wife has a friend, and her husband had been living with brain cancer for, I think, maybe 10 years. And I think it was just 2 weeks ago he ended up passing. But he had documented and kind of journaled and posted online his journey. He became a great advocate for people being aware and screening against brain cancer. But it was just really neat to hear his perspective. And he even said, hospice is so different than I thought it was. And I, without the post in front of me, but my wife was reading it to me, and I'm like, well, wait, how do you view hospice? And there's like this negative connotation. Mm-hmm. And, being in the industry of senior living, I know that that's not the case. But I came to quickly realize that a lot of people do have this misunderstanding with just the term and what it means and what it is and what it could be. And so I'm very happy to have you here today and help us kind of unpack that for folks and help better understand what it really is. So again, thank you for being here. So with that, we're just going to jump right into it. You've been described as someone who's reshaping the way people think about hospice. So help me, what are the most common myths or fears people have about hospice? And why do you think that word hospice has become such a misunderstood or even scary one for many families?
So some of the common myths that we hear is that hospice is a place you go to die. Mm-hmm. Hospice is for the very end of life. Hospice is going to kill me if I get hospice care, right? I have to give up all treatment. I have to be done fighting.
Wow.
To be on hospice. And those, I've been in hospice for 20 years, and those misconceptions have been the same. Even physicians to this moment still believe that they have to give up on their patient in order for them to get hospice care. So we have a big job in hospice. I feel like I'm fighting the world every day to talk about how to early access hospice and when you really are eligible, and how we can help, and why that misconception. Hospice was really incepted in 1978. It was passed by Medicare in 1981. They haven't done a whole lot to change really what hospice concepts are, or what we call the conditions of participation for hospice. So I think that there were a lot of hospices at the beginning of this that really were traditional. And there's very few of us that are moving away from traditional hospice to change the way we access and look at it and educate and support. communities to understand hospice.
I feel like I can relate so much in this sense, just being in senior living. A lot of times when people hear senior living, they say, "Oh, nursing home," and well, maybe a small portion of it, but it's so much more than that. And it's like, well, hospice, well, oh, end of life. Well, maybe a small portion of it, but there's so much more than that. And it's just getting people to see the full spectrum of what it really is. You said something there that surprises me and kind of worries me, is that you're fighting the perception or the knowledge and understanding of even physicians.
Absolutely.
So tell me, what are you doing to help kind of educate primary care providers and others in the area that don't fully understand all of the magnificent resources that can be offered through hospice?
Well, I'm sure you see as a challenge in senior living to access physicians is tough, right? It's even tough to access hospitals and hospital systems. They're very closed off to outside resources. So that's a big challenge, is accessing, right? So we try to get in front of physicians and kind of break down their office, like who makes decisions in the office, because it doesn't necessarily have to be the physician, right? But we do lunches. We go there often. So just 2 days ago, I was in a neurology office on the east side of town and met with a physician group there that, obviously neurological diseases would benefit from an early hospice referral because the families are struggling to take care of that type of patient in the home. And nobody knew about hospice in there. They didn't know the criteria for eligibility. The doctors writing palliative care consult. And there's very few palliative care programs that are trying to do what they need. So they referred today a patient that I'm meeting with later this afternoon. So it really is getting to the right people to get them to understand that we want to help your patients and families at home to stay in place, to age well, and that hospice isn't just for actively dying patients.
Yeah. So you mean to tell me that you did a lunch, kind of a lunch and learn?
It was breakfast at 7:30.
48 hours. So we'll call it 52 hours ago. And you got a referral today.
Yes, sir.
That's phenomenal in and of itself. Like that level of like just immediate response to, okay, well, let's try this. And now you have the opportunity to kind of show them how different it can be. Yeah.
Right.
So good for you. That's awesome.
you.
So tell me more then, how has Elevate kind of transforming the delivery of services as I think people do know them now, or some of them how they once knew them. What are you doing to kind of transform that?
Yeah, there's a lot. And, when we incepted this company, and I had the blessing of being the original employee, so I'm the OG.
Yeah.
And
COO/OG/administrator.
Right.
I love it.
Yeah. So I just really see it as a blessing that it fell in my lap, that our owners were locally owned and operated, that they wanted to change the way hospice is delivered in the state of Indiana. And I got blessed to be able to do that with my hospice philosophy and my passion for hospice. So all hospices have the same rules, right? We all have the same guidelines. We all get the same reimbursement. We're all regulated the same. However, we don't all look at hospice the same. Does that make sense?
Oh, it absolutely does. So I completely understand what you're saying. But for our viewers and for our listeners, let's break that down a little bit. And so I'm going to give kind of just a broad stroke, general expression, and then you can kind of maybe give some specifics here. The same guidelines, the same rules, the same regulations, the same reimbursement. A lot of times people see those rules, those regulations as, well, that's the way we have to do it. No. Those are the boundaries. They're creating the bumpers, if you will. And there's all of this sandbox within to be able to deliver that care however I think it would benefit that individual the best. And so you see kind of the traditional providers, and it's like, well, here's the guideline. And it's, well, let's lean up against this guideline and follow this straight line. And people like you and people like Greenwood Village South, we say, no. That's the edge of it.
That's right.
We've got all this playing field to work within. Let's do it differently.
Right.
And so maybe provide just a specific example or two of how that would kind of portray in your world.
Yeah. So we believe that when people call us, it's because they need us right away, right? So we admit patients within 1 to 2 hours of the referral coming in.
Okay.
So this little lady we talked about earlier, we got that referral at 9 o'clock. We would already be there to meet with her, but they want to meet at 3 o'clock. So we'll be there this afternoon at 3 o'clock. We admit 24/7, 365. We don't stop. And that is a much different concept than every hospice really in the state of Indiana. And we have very high visit frequency. So a lot of times most hospice companies will build just a traditional visit frequency, right? Oh, we're going to come twice a week with the nurse and twice a week with the aide. We don't do that. We build those plans of care and the visit frequency based on the patient's need. So if we have a very acute patient coming out of the hospital, they're not going home with that type of care. They're actually going to go home most likely with a level of care called continuous home care. Hospice has 4 levels of care to it. You might be familiar with routine and respite because you do that in your community. There's general inpatient, and then there's continuous home care. Continuous home care is our staff at the bedside of that patient 8 to 24 hours a day for however many days we need to aggressively manage symptoms. If a patient's coming out of an acute care setting like the hospital, and let's say you have an 89-year-old little guy that has heart failure and his 86-year-old wife is now having to take care of him, how does she know how to do that?
Absolutely.
So we put our staff there
Yeah.
to make sure that patient gets managed and comfortable and that the family is trained. And that's 100% reimbursed by Medicare, Medicaid, and most private insurances. That component, that level of care sets us apart from every other hospice in the state of Indiana.
So help me understand. So in that situation, is it, so when you talk about those 4 levels of care, is that fluid moving from one level to the next and then maybe going back? And so tell me how different that is than others. Because again, when we talk about the perceived rules and regulations, I would imagine that most hospice companies say, well, 1, and then you go to 2, and then you go to 3, and then you go to 4, and then it's done. Or you start at 3, or you start at 4.
Yeah.
And I think a lot of people is, well, 4. That's really all they know is, well, it's 4. But in that situation, would it be fair to assume that you start with that level 4 of that continuous care, that bedside, because they're discharging from that acute, and they need a lot more care and a lot more assistance at that point in time, but it would be feasible that then that could be relaxed to a level 2 or level 3, and then maybe further down the road progress back to a level 4. Whereas I don't see that, I don't hear about that with other hospice providers. Is that a fair conclusion?
So I would put the levels kind of linear, right? Where, and they are fluid, which is a word I like to use.
Yeah.
So nice job, Jordan.
That was not, I wasn't probed there. I wasn't prepped or anything.
So they are fluid, and patients move in and out of those levels of care based on their need. So when you have a patient who's very much managed, they're going to be in routine level of care. That means we have plans of care open for them, and we're seeing them 3 times a week or 5 times a week, whatever their visit frequency is. But let's say they're at home and the family gets burned out or they're going out of town, they need a respite. So we're going to call nice people like y'all
Yeah.
and say, can we have a respite stay for 5 days? We set up transport. We get the patient there. They stay there for 5 days. We see them, and we get them back to their home setting, right? General inpatient level of care happens at a skilled nursing community that has an RN around the clock, or at a hospital that will contract with us, or at a freestanding unit. And that's for acute symptom management. So the patient has pain management, shortness of breath, nausea, vomiting, change in level of consciousness. And we need to do some aggressive management for that patient. Like what we do at one of the hospitals in Noblesville is we do general inpatient there. They might have a patient on a ventilator that's coming off. We call that a terminal wean. Well, we admit that patient to hospice. We manage that terminal wean, and then we pay the hospital to take care of our hospice patient. Okay?
Yeah.
Then the continuous home care level of care is also for that same acute management at the bedside to wherever that patient calls home, right? So it could be a skilled nursing community, long-term care facility, assisted living, or a home.
Yeah.
And we put our staff at the bedside, typically LPNs, so that we can dose medications, make assessments, and change what's going on with that patient. 95% of our deaths are attended with us at the bedside.
Wow.
So that's massive.
It is massive. And one, I'd be curious to know, how does that compare with, what is the state and national benchmark for other hospice providers? And I'm not sure if you know that off the top of your head, but I'm sure. I bet, I would imagine at 95%, that's a number you'd like to share.
Yeah, so less than 2% of the hospice hours last year in the state of Indiana were continuous home care.
Wow, less than 2%.
And we're behind on the reporting, so we won't see the impact we've made in the last year until probably third quarter this year.
Okay.
So I'll be excited to see how we've changed those numbers for the state of Indiana, because we are aggressive in that level.
Now, I've got a question for you, and this is subjective. This is your perception, and this is going to be different for every individual that you provide care for, the families, et cetera. But I look at what hospice is able to provide as such a benefit to the individual receiving that care, but also for everyone that loves that individual. Someone is here to help. I can now be the son to my father. I can be the husband to my wife. I can be whatever it is. How do you see that? It's like, the question is, do you feel you benefit the patient or the family more? And I know that's such an impossible question to answer, but maybe talk a little bit about the dynamics about the benefit that you provide to not just the individual that you're providing care for, but everyone in that home and in their life as well.
Right. So, typically we get in and there's a lot of things that are going on, a lot of dynamics. Most people don't have their business in order at the end of their life. So the beauty of the hospice benefit is that we have an entire team that wraps our services around our patients and families. So we have a social worker, we have a counselor, we provide bereavement for that family for anticipatory grief, right? So we're starting when we admit the patient, dealing with any of those family dynamics that we see may generate an issue. And we're starting to have those conversations, funeral planning, advanced directives like DNR discussion, if they're a full code. How do you want this part of your life to go? We prepare 9 months to invite a beautiful child into our lives, right? But we typically prepare nothing at the end of life. And so we always have a big job to do. And then we build out how often we're seeing families, because there are typically dynamics. Sometimes the social worker and the counselor are there every day. multiple times a day dealing with dynamics if it's a severe issue. Or we're there once a month or once every week, whatever they need, we address. What was big for me when we started to build this company is most hospice companies were all required to provide 13 months of bereavement to the families after the patient passes away. But that the regulation, the minimum we have to do, like you talked about, is every 3 months, 6 months, 9 months, 12 months, we have to send a letter and make phone calls in between.
Okay.
For me, I felt that that's not enough. That's not what we're not done.
Yeah.
We're not finished when a patient passes away, when we've built such a rapport with the family. And now we have to walk that journey of 13 months, which is a whole year of first death, date of the death, anniversary, birthday, Christmas, all the things without that person being in their life. So we build out individualized bereavement plans for families. So right now I can think of one in particular where I was with the husband and wife when we admitted her, and she passed away 2 to 3 weeks later. The husband was not prepared. Yeah. That was not long enough for us to have. But we see him every week. Wow. And he comes to every one of our memorial services. So twice a year we do a butterfly release for all of our patients that we're remembering that have passed away, which is why our logo is a butterfly with a face in it, because that was important to me. And then we do, monthly support groups, available to the public as well, because we feel that we are the experts in this type of care, and it's our duty to really provide that support to patients, families, and our community.
That is to me just like I don't know what word I want to use here, but that is an example of that I could relate to in the industry of senior living, right? So bereavement, every 3 months, letter, every 6 months, a letter, every 9 months, a letter, every 12 months, a letter, call or two in between, right? I know so many other senior living providers that interpreting a regulation like that is what they do. They send a canned letter at 3 months.
Yes.
They send a canned letter at 6 months. They make the obligatory phone call in between. And one, just that approach in general is, to me, so kind of just disassociated and impersonal. But the fact of the matter is, every single patient, every single family member is going to feel and grieve and experience it just a wildly different spectrum. And to take just such a canned approach with each one is almost dehumanizing.
It's a disservice for sure. And unfortunately, that's what the industry has become, is what we can do. There's been so many hospices that pop up, one on every street practically, right? And they all interpret things a little bit differently. And some of the ownership, even with the major players in the game, it's, how can we make the most money doing the least amount? That's how I feel. And I've worked for all of them. Yeah. And, just another story, we had a 42-year-old patient we took home on a dobutamine drip out of a hospital, and we did continuous home care with him for 11 days, and then he passed. We were meeting with his mom every week. By the third or fourth week in, she was going to commit suicide. And luckily, we saved her life because she had built a relationship with us, and we saw her, and we got her inpatient therapy. And, she's now grieving appropriately. She was not grieving appropriately. I don't think there's many hospice companies that could say that they have had an impact post-death like we have had with several individuals. And those are just two I can think of. But it is, the sad part is because we access hospice so late to people, they don't have time to prepare, the families, the patients. And I think that's really such a drive that I have in hospice to get the word out. And I'm passionate about it. I don't let people just kind of give me oh, well, we've always done it this way.
Yeah.
Okay, well, this is how it should be done,
Yeah.
right? My dad was on hospice for 2.5 years post-stroke. And most hospice companies probably wouldn't have admitted him because he didn't meet all the guideline for that stroke diagnosis. He was 62. He hadn't had repeat hospitalizations, but he had weight loss. He was dependent on his ADLs. He was eligible for hospice, and he had a 4-year, decline in his trajectory of his disease. And because I'm in the industry, I'm like, I need hospice because I'm not going to fix his brain.
Yeah, absolutely. The those stories that you just shared, it's like, I know coming into this conversation that what you do provides so much benefit to everyone else around the individual that's actually receiving the services directly. But to hear that, it's like, I know the impact is there, but to hear the magnitude of impact and that story specifically about, if you were to just rely on 3 months, 6 months,
She could have been dead.
yeah. I think that's profound.
Yes.
So good for you.
Thank you.
Congratulations. That is phenomenal. That's such a testament to kind of the different approach, I guess magnified approach that you take to this process. So thank you for that. So, one of my questions was, here it is. A moment in your career that really affirmed that hospice can be powerful, but you answered that a couple times already. So I don't want to hit that one anymore. So let's talk about timing, because we have insinuated about that, and 2.5 years and 11 days and 7 days and 2 weeks. What should that timing look like? When should families or individuals start asking questions or looking into services that hospice could provide?
So I have to say that the majority of hospice patients and families over my career of 20 years helping people at this point in their life, almost all of them have said, I wish I had known about hospice sooner.
Absolutely.
So the earlier, the better, right? When we start to look at goals of care of, I don't really want to go to the hospital anymore. I don't want to keep going to all these doctor's appointments. I need help when life is getting hard at home and we have diseases that we can't make better. Just statistically, cardiac disease is the #1 killer in the country. It is not the #1 hospice diagnosis for admission. So we have a huge gap in that education. So, for heart failure patients, COPD patients, definitely cancer patients need to hear about hospice so much earlier in their journey, because we're not going to elevate hospice is not going to discontinue all their medications.
Yeah.
We're not going to not treat infections. We're going to be there to most likely decrease the likelihood of the exacerbation and then get a handle on it quickly. So it's really, how do you want to live with your disease, and knowing that Medicare, Medicaid, and most private insurances pay 100% for us.
Yeah.
So, the challenge with home health at home, right, is all of these Medicare Advantage plans, or I deem them disadvantage plans. They don't get access to the services that the patient needs, whereas hospice, we don't have that. So when a patient has an Advantage plan, we take them back straight Medicare, and we get reimbursed straight from Medicare. So there's never any of this nonsense of I can't get home health or I can't get hospice because of insurance. And then we are required to provide all medical equipment, all supplies, all medications related to the diagnosis of for why they're on hospice. So we provide all of that at home.
They don't have to worry about anything.
Nothing.
Literally turnkey
Yes.
solution
Yes.
versus chasing your tail and seemingly having to fight
Yes.
to get
A bed or a wheelchair.
Yeah.
Yes.
Which is I always find it interesting that, when you look at traditional Medicare, the individuals providing the care are the ones that are able to determine this is how much care they need based off of obviously the clinical indicators. But on the Advantage plans, as you said, it's someone maybe in an office, maybe it's AI, who knows, that's never met the individual receiving the care, determining what kind of care they should receive, which I find absolutely mind-blowing. But boy, they keep on selling those plans, don't they?
Yes, they do. And I've got a whole soapbox
Yeah.
about it, but I don't think we have to talk about it
I
here.
just say we'll save that for another
day.
episode. So getting back to kind of timing, what kind of questions should families start to ask when they're looking into that?
Asking a hospice or determining if hospice is the
I guess
level?
both. But if someone were to say, hey, maybe this is something we should look into. My physician's never said anything. What questions should they ask their primary provider or their specialist? And if they were to Elevate a call, what kind of questions should they be prepared to ask, or I guess questions they should be prepared to answer?
Yeah, there you go. Answer. So if they were to call us and say, I have a diagnosis that I know I can't cure, right? No physician can cure cardiac disease, pulmonary disease, most neurological issues, a lot of, stage 4 cancers with metastasis, they can treat them, but they can't cure them, right? So when life is getting hard and, staying at home or staying where they call home, right, in assisted living or whatever, they're back and forth to the hospital or to a lot of appointments, and they're declining, right? Like life is getting hard. That's when they need to start saying, what extra services can I bring into the home? If they were to call us, we're going to ask some kind of coined questions, right? What diagnosis does the patient have? Do they have cardiac disease, heart failure, pulmonary disease, dementia, stroke, MS, Parkinson's, ALS? Those are very aggressive diseases that have a lot of side issues, right? Or maybe they have a culmination of those things. So we're going to ask about that. We're going to ask, has there been hospitalizations? Has there been weight loss or weight gain? Declining in their activities of daily living. Like, how are they getting a shower? How are they getting dressed? Who's taking care of them? And really, what are their goals of care, right? Do they want to live out the last amount of time that they have in peace and at home with knowing there's a team of professionals that come to the home 100% covered by Medicare, Medicaid, most private insurances? Or do they want to be on that hamster wheel of back and forth to the hospital, back and forth to all the specialists that really are just monitoring the same medications that they would be on with hospice?
So then let me flip it then. When they're calling hospice providers, whether it's Elevate or others, what questions should they ask you and other providers to make sure that this is a good fit for me?
Sure. I would ask service area. I would ask staffing. How many staff people do you have with the amount of patients that you have? So industry-wide for us since COVID, because we really have to have RNs, it's been tough staffing-wise. We are staffed ahead by about 25 patients, and I try to stay staffed ahead because we never know what will happen.
Yeah, absolutely.
I can just say first quarter last year, we admitted 66 patients in 2 months and had 36 deaths. So we were burning through patients. That's high acuity. It's high visit frequencies. There's a lot of things going on. So that's something to ask. Larger hospice companies have a very difficult time staffing. And we're a medium-sized hospice for as long as we've been in the market, which is a pretty big thing to be able to come on the scene and do what we did, So I'd ask staffing and I would ask visit frequency, like how do they build that? I'd also ask if they provide all levels of care and how long it's going to take to get an admission.
Oh, that's a good one.
Yeah, because really, if you call most hospice providers now with a referral, they're going to ask you to fax an order and an HMP. Then they're going to review it, and then they're going to decide if they're going to take it. And then they're going to take a couple of days to come out to admit the patient. That's not us. You call, we come.
Wow.
We know
that's a big difference.
That's important. People don't call hospice because it's fun.
Yeah. You're absolutely right. It's you're not shopping around for a used car. It's I need help.
Right.
Like they're calling because they need something, not because they're pondering whether this is
right
the route they want to go.
Well, and our patients who have our service already have a hospice plan of care, right? So when a referral comes in for us, it's 911. We're on our way.
Yeah.
That's why we have a dedicated admission nurse to do that, so that we can be very responsive.
I think that's amazing. Just being there in the moment when they need you is kind of an invaluable benefit in and of itself. So kind of wrapping up here, if you could kind of leave our listeners with a single message, what would that be?
Not to be scared of hospice, and that we have a very big place in healthcare that most people don't want to talk about, but we do. So if you want to know more about hospice, you can call anybody on my staff, and they would love to talk about it because we all have a passion for what we do and to access it early to patients and families so they can get the entire benefit of what hospice can provide.
I'm sitting here thinking about this. What's the worst that could happen? I'm sorry, you're not appropriate for hospice. Well, that's kind of a good, right? That's.
And call us when this happens, right? And then we'll check in with you along the way. That's our goal. We want people to call that aren't eligible, right? Because then we go, okay, hey, we'll call you next month and see. Or hey, if you go to the hospital one more time, or if you're not eating well, call us back. And for us, we don't put barriers in front of getting access to hospice, where I have found working at other hospice companies that happened.
Wow.
Happens to this day.
That's interesting. That's interesting. But I love that. Don't be scared. Yes. Don't be scared. Lean into it. It is absolutely a benefit. And I think, man, it'd be amazing to get the collective perspectives of individuals who are receiving or have received hospice care, because I bet their perspective changes almost overnight, especially with that continuous care at bedside. So, Dee, I appreciate your insights. I appreciate the fact that you and Elevate are really trying to change the game and change the perception for the better when it comes to hospice care and hospice providers. But I want to leave with this question. It's a signature question of ours. If you could be remembered for one thing, whether it's personally or professionally, what would it be and why?
Let's see. Well, I think professionally, that I have been a crusader, a trailblazer in how hospice is delivered, and a blessing that I've been to people who may not have gotten hospice care because of the way that we look at hospice.
Yeah. And I think some of the stories that you shared are very indicative of you being a crusader, being a trailblazer, and making literal life-changing impacts on multiple individuals. So I think you're well on your way to blaze that trail. So appreciate what you're doing. I appreciate you coming on to the show and sharing your insights. And look forward to talking to you again in the future.
Absolutely. I'd love it.
Thanks
for
again.
having me. Thanks.